let me go over some of the ground rules. So the session is being recorded. That's something that all of you should know. As I've said, we'll have 10 minutes after each group of 4 presentations to ask questions. I hope that you'll be able to, and you'll feel comfortable asking the questions in real time. But if not, you can feel free to use the chat function. If you can, please have your cameras on, if you can, because I think it just makes it a little bit more engaging when you can see the people that you're talking to as against a blank void. Okay, so I think that is it. So I will have some closing remarks at the end, but otherwise, I think we should take it away. So the first presenter is going to be Mario Martinez Jimenez from Lancaster University. He will be presenting a poster titled "The Effects of Parental the effects of the long-term health effects of parental unemployment." Okay, so Mario.
Yeah, I have some changes in my title. So just thank you for the introduction. My name is Mario Martinez Jimenez. I'm a PhD student at Lancaster University. So I'm going to present my second PhD chapter that is titled "The Long-Term Health Effects of Parental Unemployment." So what does this paper do? It estimates the impact of parental unemployment spells during their children's early, mid, and late childhood on child's consequent mental, physical health when they become young adults. We exploit data drawn from the British Household Panel Survey and the UK Household Longitudinal Survey, and we employ 2 empirical strategies: a correlated random effects probit model and a generalized estimating equation random effects estimator. So previous evidence in this research topic has present mixed results, where some papers find that parental unemployment worsens children's mental health, and others doesn't find any effect. So we try also to exploit the mechanisms behind this relationship. So as the data we use, as I said, we use the British Household Panel Survey and the UK Household Longitudinal Survey. And we employ, we have a sample of people born between 1978 and 1993. And we have information from the biological, adoptive, or step parents during the entire childhood and the parental labor characteristics. So as I said, we employ a correlated random effects, mostly because this seems appropriate to allow modeling the binary nature of the dependent variables, while still accounting for the individual level time invariant and observed heterogeneity. And we also employ this generalized estimating approach in order to account also for the structured data set. And we use outcome variables related to mental and physical health, also prescriptive medicines and biomarkers. So what we find, our results indicate that parental unemployment experience at age 6-10 increase the probability of having risk of mental illness, ill health. We also find that the long-term effect of parental unemployment experience at age 11-15 is on average increase the probability of reporting long-standing illness. And we also find for these children that experience parental unemployment increase the probability of consumption of prescribed medicine. So to conclude, overall, the results of this study may help welfare institutions to design policies that may alleviate the long-term vulnerability of children growing up in families with weak labor market attachment. So thank you for your attention.
Thanks a lot, Mario. Okay, so next we are going to turn it over to Rolando, who will talk to us about the effect of child time poverty on human capital accumulation. Rolando is from University College London.
Great, thank you. I don't know if you can see my presentation now.
Yes.
All right. Well, hello, my name is Rolando Leiva. I am a second year PhD student at the University College London. I will be presenting my work on time poverty and child development. I know that most of the people here on this call are academics. And I know academics suffer of time poverty. You know, one of the things that I've heard more frequently from academics is that they do not have enough time. They always rush to meet deadlines, to submit papers, to submit projects, etc. This is one example of what is known as time poverty in economics and sociology. Time poverty is defined as not having enough discretionary time because most of the time is devoted to committed activities, such as sleeping, or to necessary activities such as work. There is a broad literature on time poverty now, but it has almost focused exclusively on adults. There is an implicit assumption that children are time poor, time rich, sorry, because children do not have to work, or children, for instance, do not have to mark exams in January. However, in the context of low and middle income countries, especially in the context of these countries, children may spend too much time working or too much time taking care of the siblings, etc. So I tried to fill this gap by studying child time poverty in Peru. I used a cohort of children from 5 to 15 years, and I have information about their time use, and I have information about some cognitive tests. So I apply or I estimate a cumulative value added model, and my preliminary results are that there are gender differences in time poverty prevalence since the early childhood. As you can see, for instance, in figure 1, the prevalence of time poverty is higher among girls than boys at the age of 5, 20%, a prevalence of time poverty 20% for girls versus 17% for boys. And my preliminary econometric results show that experiencing time poverty at the age of 5 has a negative effect on vocabulary development at the age of 15 for girls. So we find this gender gradient, and we think that visualizing and understanding time poverty is key for closing these gender gaps that emerge since the early childhood. Thanks for listening.
All right. Thank you. So the third person on the program, Cornelio, does not appear to be here. Cornelio, just making sure, I don't see that name in the list of participants. So why don't we go to Florencia? So we'll, Cornelio might be missing in action. Florencia, why don't you go? So Florencia, you'll need to unmute yourself. Florencia will be talking about early life nutrition and academic achievement, evidence from a large public program in Chile.
Great. Now I can start. Thank you. So in this paper, we are analyzing a very large public program in Chile that distributes powdered milk for infants, pregnant and nursing women, and children. This program actually started in the 1950s and continues through today. So it's one of the largest, widespread, and most relevant programs, interventions in Chile. This program was aimed at reducing malnutrition and infant mortality. And what we do is we go beyond the nutrition itself, and we are going to study the educational outcomes related to this. So what we do is we link the milk distribution intensity in each province of birth to each child's educational outcome. We use data from the census, so individual level data from each census, and we are going to study the outcomes from the cohorts born from the 1940s to the 1980s. So it's a long period of time. And basically we have several specifications. We do siblings fixed effects, and then we do the full sample with provincial level trends and many other texts. But what we find is that in children born in provinces with higher intensity of milk distribution have better educational outcomes when they are in primary school. So they have better grade for age markers. And they also have, for example, who are slightly older than primary school, like they have better primary school completion rates. So this happens mostly for cohorts born in 1970, for the 1970 census and the 1980 census. By the time we get to the 1990 census, which is the last one we have, there isn't a lot of effect, probably because the bulk of the malnutrition problem was already solved.
1 minute.
Yes, I'm almost done. So basically what we are doing is we argue that improving early life nutrition paved the way for better cognitive outcomes, and those translate into better educational outcomes, both in transition, so in grade 4 age, and in primary school achievement. And thank you.
All right. Thank you, Florencia. Okay. So I'm still going to stick with the program. So, you know, instead, even though we haven't had 4 presentations, we've had 3. So for the next 10 minutes or so, I'm going to open it up to questions. And for each of the 3 presenters that have gone, if there is a particular question that you have for the group, you know, so if there's an area on which you want feedback, or there's something that you are, you know, you're kind of grappling with in your head and would value some discussion, you know, feel free to ask or bring that up as well. Okay, so I'm going to open it up to questions. Yes,
so
Florencia, go ahead.
Yes. So I have a question for Mario. I know it was very quick and you didn't have time, but I was wondering if you could talk more about the mechanisms. So is it like increased conflicts? Is it like a financial stress? Or like why do you see like this difference across the age group in these terms?
Thank you, Florencia, for your question. Yeah, I didn't have too much time. Also, it's a work in progress paper, so we are doing now the mechanisms, but what are we know from previous literature is like the gender of the parent that suffered unemployment, it has a difference. Sometimes when the mother is unemployed during the childhood, it has a positive impact to the children, and when it's the father has a negative impact. Also, the gender of the child, it has some differences. And yeah, also we want to look at the household situation, and yeah, also the other mechanisms. Well, maybe it will be interesting also, like an open question for the audience, if you can find other different mechanisms that can play a role in the impact of suffering, of the impact of the parental unemployment on children's future health. So yeah, the ones that we have in mind are to explore them, like the gender of the parents, the gender of the children, and household situations like number of people that is living. Also the health behaviors of the parents, if they also we want to check if they are having some welfare, if they have support of welfare institutions, like maybe they have some income through the welfare institutions, so if they play a role. But thank you for your question.
Thank you. Femi, you have your hand up.
Yes, my question is for Florencia. It's a quick one. You know, I recognize that you're trying to, or I will assume that you're trying to at least model as close to possible causality by doing the siblings fixed effects. My question has to do with the use of milk. And if you're why only milk as a proxy for nutrition? It seems as if that's a little bit restrictive. That's the one. And I do know that kids, when they're born, either getting breast milk or whatever, but I was just wondering why. And I'm not sure that these kids that you're looking at milk just within the first year of life. I'm assuming going further than that. So it's not breast milk per se, but going further. So I'm just wondering why, if there's a limitation to your work with just looking at milk versus other things. So just help me with that.
Yes, thank you. So this program distributes powdered milk. So the idea was to focus on infant mortality rates. So it started by improving the nutrition of mothers while they were gestating and infants up to 2 years of age. We are using census data, so we do not have other types of nutritional markers. The only data we have is basically how many kilos of milk were distributed in each province. That said, as the program evolved, they did include more other types of food products for older children. But right now we are trying to capture like the exposure to this program while children were like either in utero or in the first year of life. And in that period, that would be a big chunk, like milk would be a big chunk of their nutrition.
All right. I don't see, oh, Lucy, I see your hand up.
Yeah, just kind of a clarification follow-up on that one, Florencia. So is this infant formula, or is this kind of milk that the mothers can make use of as well?
That's a very good question. It's both, actually. So it started as formula, and then for mothers, they would have something that had another kind of formulation that had I lost the names in English, but they had supplements specifically for nursing mothers or gestating mothers. It is true, and that's probably what you're thinking, that there is some anecdotal evidence that like they would share since it's powdered milk, like you could share it among the household or put it on your coffee or stuff like that. But at least in the beginning, like in the 50s or 60s, that should not be like a big problem.
Well, I wasn't thinking about that. Oops, sorry, I just kicked my desk. I wasn't thinking about that so much as the mechanism of benefit. If you're feeding the mother versus feeding the child, and if there's a benefit that's happening sort of in utero versus postnatally, then there might be a slightly different sort of effect there. But it's interesting that you say that the policy changed and that the kind of milk changed. Is that something that you can kind of look at in your analysis?
Yes, that's a work in progress, because those changes happened more like in the 90s. So that's what we stopped earlier, our analysis. It's a good point that the effect would be probably different whether it's in utero or after, but we cannot distinguish that effect. We are putting it all together in one bag and getting like just one estimate for that. It's a good point. Thank you.
Okay, great. Does anyone have any additional questions? Okay, so if the answer is no, we will begin with the next group of presentations.
Well, if we go into the another next of presentations, I would like to ask another question to Florencia, to be honest.
Okay, please go ahead.
Yeah, I find it super interesting topic. Well, we know that we are restricted to the 3 minutes, but it's super interesting topic. But I'm really curious about, I know that it's only 3 minutes, but I'm really curious about the empirical strategy that you follow, this maternal fixed effects. And I don't know too much about this policy that you are studying. I suppose that is like they implement this policy, well, this policy like in 1 year. So maybe you can compare before and after these children's. I don't know. I'm guessing. I'm guessing because I don't know the policy that you are, because I don't have too many information, and you couldn't explain it either. So.
Yeah, no, it's a very good point. The policy it developed gradually over time, so there's no sharp time when you have a before and after. So it's not that clean. So we basically are trying to get like a intent to treat estimate of the intensity. So we have a measure of how many kilos of milk per normalized by the number of births in each province. So that would give you an idea of how likely it is that each type would get like their yearly allocation of milk, and get like an estimate of how likely it is that you get improved educational outcomes out of getting more milk, basically. In the case of the specification with maternal fixed effects, what we have is we have siblings in the same, who are born and raised in the same province, but have different allocations of milk. So there we can compare like within family, if more milk improves your outcome.
How is possible that in the siblings living in the same household can have access less or more to this milk?
In the year of birth. So the
the year of birth, so
they are born
years of birth. Okay,
yes,
yeah. Okay,
exactly. So if you're born in a year that was like more generous in their allocation, you get better outcomes.
Okay, sounds super interesting. Thank you.
Okay, excellent discussion. So let's keep this moving, and remember that we'll have time at the end again for more interaction. Okay, so let's kick off the next group of 4 presentations. So first is Femi, who is at University of Houston, Clear Lake, and she will be talking to us about the effect of adolescent fertility on educational attainment in Nigeria, a propensity score matching approach. Femi, take it away.
So thank you, and good afternoon or good morning or wherever you are. My paper is on effect of adolescents' fertility on educational attainment in Nigeria, and we're trying to look at use the propensity score matching approach. So just a quick background while we're still talking about teenage childbearing. It continues to be a major concern because a teen mother has potential to face health, social, and economic disadvantages, specifically when we look at countries and situations where we have early maternal childbirth with young adolescents, children under 15, facing higher risk than older adolescents. And once you've been a young mom, then it keeps going from there. Where we know and recognize the data on fertility among girls under 15 is relatively underreported, and usually it's occurring outside of marriage. Why is this an issue in Nigeria? Well, Nigeria happens to be one of 4 countries in the world with the highest early adolescence birth rates of 10 births per 1,000 for girls who are 10 to 14 years of age. That's a big problem. And like I said, we don't usually really have good data for those people really to do any serious analysis, but it goes on to when you're 15 to 19, where we have a lot of data for, and just some data on the age-specific fertility rates for those age group here. In Nigeria, by age 19, 30% of teenagers have started having a child. A little bit about what's been done in this area. Many literature initially were looking at associations or correlations of teen pregnancy and socioeconomic outcomes. Some empirical data has looked at attempt to identify causal effects, looking at siblings or sisters fixed effects, using instrumental variables like miscarriage, age at menarche, abortion. And our work really just has some issues with being able to use good instruments for the data set that we have. So some studies have looked at propensity score matching techniques to sort of construct this counterfactual group for teenage moms. None of them has used that in Nigeria. So our study is examining this effect of teen fertility on educational attainment in Nigeria. We looked at the 2018 Nigerian Demographic and Health Survey, and we construct this match sample of fertile teens who've had a birth or are pregnant in the last 5 years of this DHS survey and non-fertile teens using the nearest neighbor matching algorithm. And one of the results we're finding, which is consistent with literature, is that the causal effect of being fertile is a reduction in education by 2.5 years between the fertile and non-fertile teens. And when we also looked at that educational attainment outcome in terms of having completed secondary school, that reduction is the probability of completing secondary school reduces by about 25%. So thank you.
All right, thank you. And next we have Lucy Abel, who will be presenting about, so her paper is titled How Are Maternal and Fetal Outcomes? Okay, hang on one second. Do I have that wrong?
So I changed my title.
I'm sorry, according to the program,
Yes,
Lucy,
I changed my title as I went through because I came up with a better one, but you're absolutely right. What's in the abstract originally is
okay,
correct
great.
as well.
Great.
The project stayed the same.
Okay.
So this is a little bit different from what we've had so far. This is economic evaluation rather than health policy. And what I have been doing is, I should say I'm a PhD student and in my second year, and this was my first year systematic review. And what I was trying to understand in doing this research was how are, particularly in cost utility analysis, so using QALYs and DALYs, how are health outcomes in pregnancy sort of constructed? And the reason I think this is interesting is because in pregnancy, you're dealing with a health outcome, which is both maternal outcomes, but also outcomes for the baby, what I call fetal outcomes. And that raises a number of sort of practical and ethical challenges if you're thinking about the cost of, say, averting something like a stillbirth or a miscarriage or some kind of health problem like prematurity or something like that. So what I tried to do was look at, as far as possible, the full range of cost utility analyses that have been done in pregnancy across countries, going back over the last sort of 50 years or so. And I found 127 from a variety of settings. And I looked at where QALYs and DALYs were used, whether maternal outcomes were included, whether fetal outcomes were included, when they were both included, and if they were both included, how they were valued and constructed and combined. And what I found was enormous inconsistency, even within countries, even within health conditions. So what this kind of flags is that there's a lack of a kind of theoretical basis for how we're constructing QALYs in pregnancy or DALYs in pregnancy. It was kind of, there was a lot of making things up as you go along in the results, and there was a lot of sort of unstated assumptions about when it's important to include fetal outcomes, when it's important to exclude fetal outcomes, when you might decide that maternal outcomes are important, when you might decide that they're not important. So what I am hoping to then go on and do with this research is to start to come up with what I've done on the sort of right of the poster is a bit of a taxonomy of all the different ways that maternal and fetal outcomes have been constructed. So by constructed, I mean things like how long do you assume the life expectancy of that baby or that mother is going to be? What utility value, so what quality of life are you assuming that that baby or that mother is going to have? And what discount rate do you apply to those outcomes, that sort of thing. So I'm starting to come up with a taxonomy of all of the different ways that those choices are being made, and what those choices tell us about what researchers are assuming within that sort of decision making. And is there a way we can start to tease out those assumptions and see whether they match our societal assumptions and our societal preferences within different countries?
1 minute.
That's kind of all I wanted to say, because I was assuming we'd have 2 minutes, and I also talk very, very fast. I think the only extra point that I'd like to make is I touched on this a little bit when I was running at 1,000,000 miles an hour a few seconds ago. Sometimes studies only include maternal outcomes, and sometimes they only include fetal outcomes. That's the figure I've got in the top right, and sometimes they include both. When that happens, it's usually based on the assumption that the outcomes excluded are unaffected by the intervention, but actually different studies made different choices about whether they considered those outcomes to be unaffected. So it's just another illustration of the way that there's a lot of inconsistency in what's considered to be important or not important within pregnancy evaluations. So yeah, that's me.
All right, excellent. Thank you. Okay, so next up is Jessica King from the London School of Hygiene and Tropical Medicine. Her paper is titled The Long-Term Impact of the Ebola Epidemic on Access to Reproductive, Maternal, Newborn and Child Health Care in Sierra Leone. Jessica?
Hi, thanks. Hopefully you can see my poster. Sorry, I think it's a bit smaller than I intended, but I'll try to explain the key results. So this study was to look at the longer term impacts of the Ebola epidemic, in this case in Sierra Leone, on access to RMNCH care and also affordability of care more generally. So there's a lot of evidence from Sierra Leone and from the kind of other countries in West Africa that experienced the 2014-2016 Ebola epidemic. A lot of evidence that during the time of the epidemic, access to care was vastly reduced. The proportion of women who attended for fertility delivery, who attended for antenatal care, children getting vaccinations were all down. But there are a few evidence gaps that still exist on that. And so the first one is the kind of the longer term effect. So we kind of only have data from about up to 2016. We don't have much evidence about what happened in longer term. Also, all of the existing evidence comes from facility surveys. And there is a sort of concern that actually the epidemic itself would have affected data quality. Facilities might not necessarily be recording data consistently for RMNCH care when they're focused on an Ebola epidemic. So we decided to use a household survey, in fact, two sets of household surveys, one from 2011 and one from 2018, so before and 2 years after the end of the Ebola epidemic, and it's the Sierra Leone Integrated Household Survey, which mostly measures living standards, but also includes questions on access to care. And it's a difference in difference study, and the kind of exposure was being in a chiefdom. So there are around 150 chiefdoms in Sierra Leone. The exposure was being in a chiefdom that had a high epidemic, so it's over a certain number of cases. We were comparing those chiefdoms to the sort of unexposed chiefdoms that had fewer cases, and we used a propensity score weighting method because, not surprisingly, those chiefdoms are already quite different from each other. So there was some concern that you couldn't assume parallel trends at all. For example, chiefdoms that had more serious Ebola epidemics were also more likely to be urban. What we found actually on a whole series of maternal child health indicators is no effect of the epidemic on almost all. There was a sizable effect, a 12% point of reduction in skilled provider at birth, but otherwise actually no impact. It's hard to say whether that's to do with policy to kind of re-strengthen the system, or actually possibly just to do with a kind of the sample size not being big enough with all of the standard errors to detect an effect. So definitely no evidence to say that there has been a long-term impact, but we can't necessarily dismiss the possibility from this evidence. Thank you.
All right, thanks a lot, Jessica. And now we'll turn it over to Chibo Chikwendu, who is at the Health Strategy and Delivery Foundation. His paper is titled Costs of an Integrated Model of Maternal Health and Non-Communicable Disease Package of Care Services, Estimates from 2 Nigerian States. Chibo, take it away. You might need to unmute. Okay, there we go.
Yeah, thank you very much, and good day once again to everyone. I hope you can see my screen. Yeah, so this paper is about a costing study that was conducted in Nigeria to estimate the cost of a model of integrated maternal health and NCD services. So it was part of a pilot project that tested strengthening of integration and quality of maternal health and NCD care against the traditional approach to providing these services to women of reproductive age. So this approach to care became necessary as non-communicable diseases are gaining more prominence as indirect causes of maternal mortality and morbidity. by predisposing women to preeclampsia and eclampsia during pregnancy. So the specific objective was to provide evidence on the cost implication of introducing this new approach compared to the traditional approach to care, and also to estimate costs in order to support possible planning and budgeting for scale-up of the model of care. So our method actually involved, was a cross-sectional quantitative study that involved health facility sample from 2 states where the pilot project took place, and the cost was done from a health provider perspective, and only financial costs were considered. And then we also used a mix of top-down and bottom-up micro-costing techniques in allocating costs to the individual services and to the entire package of care using an Excel-based model. So for the findings, for the first state at the PHC level, the traditional model of care was found to cost about 45,419 Naira, and then the integrated package of care was about 46,065 Naira, which was just about 1% increase from the traditional model cost. And at the hospital level, it was about 78,486 Naira for the traditional model of care, and 78,750 for the integrated model. Again, it was less than 1% increase from the original cost. And in the second state, so in the second state, at the level of the PHC, we had just about 2.9% increase in the cost from the traditional model to the integrated model of care. And at the hospital level in Lagos, we had also less than 1% increase from the traditional model cost. So we also determined that hypertension care was the major cost driver of the package of care cost. And in terms of inputs, drugs and consumables were the major cost drivers ahead of personnel and operating costs. So we concluded from the results that the costs of the model of integrated maternal health and NCD care services were quite comparable across the states and to the estimates from other studies that we reviewed. And most importantly, the cost of the integrated model of care did not differ significantly from the costs of the similar services when delivered through the traditional model of care approach. Thank you for listening.
Thank you, Chibo. So with that, we come to the end of the 4th paper in this session. Now, looking ahead to the next 4 presentations, it seems like we only have one of those 4 who is attending. So the first 2 and the last paper, the presenters don't seem to be here. So Vimbai, why don't you go ahead and present, and then we can, then take questions and then open it up to general discussion.
Sure. Dr. Chikwebu needs to stop sharing so that I can share.
Sorry about that. Yeah, thank you.
So Vimbai is at the University of Cape Town. So you guys will be hosting us in 2 years, right? Okay, so she's
yes,
okay,
we will.
Thank you. There was a little bit of a lag, but thank you. So she's going to be talking about an economic evaluation of psychological treatment interventions for common mental disorders in low and middle income countries. And this is a systematic review. Vimbai?
Thanks for the introduction. So I'm a PhD candidate at the UCT Health Economics Unit. I wasn't going to do an introduction to the study, but since we've got a little bit of time, I'm going to do so. Common mental disorders are defined here as depressive anxiety and alcohol use disorders. It's projected that by 2030, these conditions led by depression will be one of the top 3 leading causes of disability worldwide. And in low and middle income countries, CMDs are largely untreated, and they co-occur with chronic conditions such as HIV and diabetes and now COVID-19, presenting a significant disease and economic burden. So psychological treatments influencing thoughts, behaviors, and skills are promoted by the WHO as first-line treatments for CMDs. Although there's a substantial evidence base on the effectiveness of treatments, economic evaluation evidence is limited in low and middle income settings. So the primary focus of this review is to report on economic evaluation methods and appraise the quality of the evidence base on psychological treatments for common mental disorders in the middle income countries. We identified about 4,000 papers and 22 were included in our analysis. We noted a marked increase in publications from 2017 with a concentration of evidence in Southeast Asia. Our findings were that most of the studies were cost effectiveness analyses and cost utility analyses, reporting healthcare provider and or societal perspectives. Time horizons varied and were generally 12 months or less, as most of the studies were trial-based, so the time horizon was typically linked to the duration of the trial. There was a wide range of outcome measures used in the evaluations, but the PHQ-9, looking at symptom severity for depression and anxiety, was the most frequently used in CEAs and the QALY in CUAs.
1 minute.
The client services receipt inventory tool adapted for different contexts was widely used in measuring costs of services used, and only a few studies reported excluded costs and costs related to screening. Staffing models using non-specialist health workers were used in the majority of interventions, but we noted limited analyses around the impact of work scope and time use on the cost models presented. Although most studies reported that treatments were cost-effective or potentially cost-effective, inconsistencies were noted. One of our recommendations is for researchers to use consistent methods when assessing value for money, for example, comparing societal ICEs to a demand-based threshold, rather than cost-effectiveness thresholds reflecting the opportunity cost of health spending on the margin, and measuring non-specialist health worker time using context and intervention-specific tools to capture variations in time use and scope of work. We use the Drummond and Jefferson checklist to assess quality, and one of our limitations is the inherent subjectivity of the quality assessment checklist. Thank you to my co-authors, and thank you for listening.
All right. Thank you, Vimbai. Okay, so at this point, I will open it up to questions and discussion. So this is specifically to the last 5 papers. So that includes the presentation by Femi, Lucy, Jessica, Chibo, and then Vimbai. So questions? Chibo, go ahead.
Thank you very much. So my question is actually for Femi. So Femi, thanks for the presentation. So I just wanted to find out, there was a reduction in education by 2.5 years. So I just wanted to find out, was this a sort of nationwide average, or was it for a particular region of the country? Or even if it's the nationwide average, did we see a preponderance of such, pattern in some, regions in the country than others?
So you may want to unmute. Femi, I think this question is for you.
She's frozen.
Oh, there we go. Okay.
Okay, can you hear me? Okay, I wasn't sure if I should go ahead and respond. It's a nationally representative data set, the National Demographic and Health Survey. However, I would warn that when, I didn't have time to show the descriptive statistics, but most of the teenagers are in the northern part of the country. So there's like 4 or 5 states in the northwest or northeast that a lot of this is going on. And in fact, one of my descriptive statistics shows that many of the teenagers who are having babies are in this region of the country in the north. They're Muslim, they're married. So that my full data slide PowerPoint e-poster that I have recorded shows those descriptive statistics. So that's what it is. Many of them are in the northern part of the country, in a nutshell.
So I guess maybe just to follow up, if you have because I'm not, I don't know how large your sample is, but if you have the sample size, it might be useful to look at, so to kind of disaggregate the results in his case. So in Chibo's case, he's asking, I guess, for disaggregated results by region.
Yeah, so we didn't disaggregate by region, and we do have a large sample. Well, sorry, let me take that back. We do have a large sample size, and we did go and look at it just for the northern states, and these results are not changing that much. So we went in, so that's why we went and just looked at them as a whole. And on our full paper, when it get published, we'll talk about that. So thank you for that point.
Okay, and Femi, your hand is up. So
yeah, so my question, I have two questions, and one is for Lucy and the other is for Jessica. So with Lucy, I think, thank you for your nice systematic review, but when I look at your title, your new title, I was getting a little confused because pregnancy is a condition. And I think what was missing in your review is being able to look at specific interventions. So when I look at Vimbai's systematic review at mental health, they're looking at specific intervention. And I think when I was looking at CU, cost utility and QALYs and DALYs for pregnancy, you're going to find inconsistent outcomes because there are so many different interventions you can be looking at in pregnancy. Are you looking at smoking cessation in pregnancy? There's so many things that can be. So I think it would help your work if you're looking at pregnancy with specific to an intervention and not just pregnancy and cost, because there's so many different things, and it would help you organize your thought better that way. And for Jessica, I was just thinking that your work on Ebola is really nice. And it's also really still pertinent with regards to what's going on with the pandemic. So I think in terms of policy implications, you can strengthen your work if you are able to do some sort of simulation of, you already have those data pre and post Ebola, and sort of, can we simulate this towards what could have happened to the pandemic, to COVID-19 pandemic specifically, recognizing that you didn't really find much difference, but still, I thought that might be interesting to tie it into the current existing pandemic. Thanks.
Thank you, Femi. And do either of the presenters want to respond?
Yes, please. That's a really great point. I really appreciate that. And I completely get what you're saying about pregnancy being a condition. Sort of what I meant by that is, and it's a challenge of the format. There were, let me just check. Yes, I came across 50 separate health conditions within pregnancy that were included in this. So that varied from preeclampsia to nutrition interventions to surgical interventions, the full gamut. And the reason that I wanted to have it that broad was because I wanted, because I'm looking at QALY construction, I wanted to see if you're taking, I suppose the point is that the interventions lead to similar outcomes. So you're, from a cost utility point of view, you're trying to get a healthy mum and a healthy baby out at the end. That is consistent regardless of what the health condition is. So you can compare, if you're avoiding a miscarriage, whether that's from syphilis or malnutrition, that's still a miscarriage that you're avoiding. So the outcome is the same. So you should see some consistency in how you're constructing and valuing that outcome. So that's why that was kind of my justification for including everything. But I do take your point that there could be a case made for narrowing down. The problem is that when you start to narrow down, you narrow down very, very quickly. So 50 turns into, I had 127 studies. I think the largest in a single health condition was only about 10 studies. So you lose a lot of data if you then sort of refine down. So that's why I've gone broad. Obviously 50 different health conditions, you can't fit that on a poster. But I do appreciate that does mean it comes across a little bit chaotic in a full paper. I'm hoping to be able to kind of elaborate on that a little bit more, but I do appreciate your point.
All right, great. Thanks a lot, Lucy. And Jessica, did you want to respond?
Maybe with a kind of further question, because certainly we do in the wider paper discuss the implications for COVID-19, and it's obviously one of the things that motivates this piece of work, trying to trying to say in previous epidemics, what has the longer term impact been? You mentioned, I think, trying to simulate what the outcome would be. And I suppose I get a bit stuck there because, yeah, I'm not sure exactly how you do it, whether you would kind of look at the impact on health facilities during both epidemics and then try and say that a certain decreased utilization during the epidemic then translates 2 years later to something else. I think that would be a really interesting approach, but I'm trying to work out how you could take that approach and say, okay, if there was this impact during Ebola, then we would expect this impact after COVID, because they did, I think they did obviously impact the health systems in different ways. So I don't know if you have any suggestions or ideas on that.
Not specifically, I hadn't thought it deeply, but I did think that if you see some sort of pattern, and I recognize the data 2011 and 2018, and now we're in 2021, but that you could argue that and come up with a bunch of assumptions on why you would project it towards COVID in that sense. So it would require some more thought.
Okay, so let me jump in really quickly here. And again, I know that this is not a lot of time to get your findings across. But Jessica, now that we have time, can you talk a little bit about kind of the, what you think is happening? So it's true that you only seem to have the one statistically significant result, but the general pattern of the results kind of seems to be in the same direction. So can you talk about, what you think is happening? Is it that, because of the Ebola epidemic? So for example, do you think it's more of a household or demand side issue, or do you think it's a health service, supply issue that's driving those findings?
It is difficult to say, and I do include in the wider introduction, there was something I found about 10% of healthcare workers in Sierra Leone died of Ebola during the epidemic. So to me, it makes a lot more sense that it's going to be a kind of supply side issue, that there just aren't the skilled providers available. And there has been a little bit, I think mostly of qualitative work, that has suggested that kind of the trust in the health system has bounced back. So I would say I lean towards, from sort of separate evidence, I lean towards the idea that it's supply rather than demand. I think also because the only statistically significant result we had was that specific one about the skilled provider at birth. And that was the sort of by far the largest effect estimate, whereas things like just attending the health facility, the impacts were smaller and not statistically significant, which again suggests that it's something specific to do with human resources. But it's really hard to pull apart, I think, particularly from this data, which is very much just a kind of accessing level. So yeah, it's definitely an open question. And if anyone kind of has ideas about how to pull this apart more, I'd be really interested, because I do think that's something, trying to explain these patterns is really quite difficult.
Yeah. So I think that's interesting, and I concede that it's always tricky to try to, once you start getting into mechanisms and trying to, so attribution can be tricky. But related to the point that Femi was making about, can you draw any parallels between, what happened as a result of the Ebola epidemic, and can you use that to say anything about the likely effects or the potential effects of, of the COVID, in this case, pandemic as against epidemic? So I think when you start thinking about mechanisms, because with COVID, for example, we know that, and I've seen a bunch of studies that have said that utilization went down, but it's demand driven, right? So that women, for example, would be, or individuals more generally would, were less likely to use healthcare services, discretionary healthcare services, because they were afraid of getting infected. And whether that, so if you think it's more of a supply side story, anyway, I guess my point is that I wonder if thinking through the mechanisms, even if it's speculative, will help us learn something about, what might happen with COVID in the long term as well.
Yeah, that is really useful, and I think possibly a kind of rewrite of my discussion with a more kind of approaching each mechanism and then thinking about implications for COVID-19 might be an informative approach. So thank you.
Vimbai, go ahead.
My question is for Chigbo. I was wondering if you've included costs of capacity building, because here, integration of services also something that's a priority, and but capacity building was one of the major things that's needed to for that to happen. So I was just wondering, maybe it's included in your staff costs. I just wanted to find out if you've included that.
Yeah, thank you very much, Vimbai. Yeah, so you're quite correct. In any situation where you want to achieve integration of care and also improve the quality of care, there's always the capacity building component. So if you look at the figure under the methodology section, you will see the costing model, and then you will see all the things that contributed to the cost. That program cost was actually one of them. And then under this program cost, we have the cost of capacity building, costs of some one-off system strengthening, interventions that are required to make the facility service ready to be able to integrate and also provide, a higher quality of care. So capacity building is actually part of it, and is one of the things that really contributed to the higher cost of the integrated model care than the traditional model of care approach.
Okay, thanks a lot, Chigbo. Does anyone have any other questions? Femi, I see your hand up. Go ahead.
I wanted to follow up with that with Chigbo. So do you think that is there plans to do this across other states in Nigeria? And given that you've looked at Lagos and Abuja and they're somewhat comparable, what is your a priori expectation if you're doing it across the different states, if you're able to do that? If it's something that can be, scaled up to the rest of the country?
Yeah, so thank you very much, Femi. So considering that this was a pilot study, we were hoping that after the pilot, and especially with encouraging results that we started getting from the pilot, we were kind of expecting that, other states might want to adopt this. But, there was actually this concern among the stakeholders on your integrating care is going to probably cost so much. And what is happening in the country, there's tightening fiscal space, and all that. It's kind of getting more difficult to mobilize resources. So that was actually one of the reasons why we insisted on doing this cost, to demonstrate to them that really the difference is not so much when you really look at it. And this was what we tried to demonstrate. And now that we're happy that, the cost differences are just marginal, and it's just marginal at this point. In the long run, when you look at when you compare this cost to the long-term outcomes, you will see that there are actually some benefits, that you will get in the long run, that there might actually be some cost savings when you prevent these women from coming down with certain complications. So in the long run, there might actually be cost savings. So this is actually part of, what were included in the advocacy messages that we are, going to use to advocate or push for scale up in the other states. So it's something that we feel can actually be scaled up in the other states of the Federation.
Excellent, excellent. Okay, so we still have a few minutes left. Any other questions or comments on all of the presentations? So now it's open to everyone. Lucy, please go ahead.
I had a question for Vimbai about what kind of interventions you saw in your analyses, in your systematic review. what kind of interventions are being conducted for these sort of less severe mental health issues? Oh, sorry, you're on mute.
Sorry. When you say what kind, do you mean in terms of the type of psychotherapy, or?
I guess I was sort of asking, is it psychotherapy? Is it pharmaceuticals? Is it, you know, I don't know, CBT or public health interventions? There's so much you can do with mental health. So I was just curious what's being tried in sort of lower income settings.
Okay, so what I was looking at was psychological treatment, so psychotherapy, psychosocial interventions. So I included ones where psychotherapy was a primary intervention, even though there would be some some pharmacotherapy. So it was mostly psychotherapy. And the types of treatments were mostly CBT. There was a bit of behavioral activation, so it was problem solving, and there was one intervention where they also included an economic intervention alongside the psychotherapy intervention. So yeah, I was focusing on psychotherapy.
Okay, any other questions?
I have a question for Chigbo.
Yeah, go ahead.
But it's Chigbo, this is not a question. I wonder if he's still there about his research. It has to do with my results. And even though I'm Nigerian, born in Nigeria, but I haven't lived there in so many years. So, you know, the results of my work, it's clearly an issue of child marriages in Sharia law countries, states in Nigeria. But the way I'm presenting the results, you know, I feel like from a political perspective, it's a little bit hard to come out saying, oh, you know, stop marrying these girls young. Muslim older men stop marrying these girls at a younger age so they don't lose out on education. So that's why I left, since the result is only stronger if I just focused on this two northern states. I'm still leaving it as a general countrywide issue rather than making it that strong situation of what we know what it is, but still talking about it. So I guess I don't know, what I'm saying is that what's more politically, you know, in terms of trying to change issues, teenage pregnancy issues, what's the most politically feasible way of presenting your results without it being shut down, that, you know, you can't change Sharia law. So that's just maybe it's a comment. I don't know.
Chibo, did you maybe have a response for her?
Chibo is our local Nigerian resident. And
Chibo, you'll need to unmute.
Yeah, so please, I think I had a slight distraction when that question was being asked. I don't know, could Femi just quickly you know, come around with that again? Sorry.
It's long, but I'll keep it short. I guess I was saying that based on the question you were asking me, the reason that this presentation is, the results are presented at the national level rather than just looking at, you know, Bauchi state or the 2 or 3 northern states that really have the particular issue, is because of this being sensitive to, I was saying, it's really a Sharia law child marriage issue, and really not wanting, when you're trying to present your results nationally, not wanting it to be this discussion of, you know, not marry older Muslim men don't marry these young kids and get them pregnant at 10 to 14-year-olds or 15 to 19. So that's why the result is being presented more at the national level, because it doesn't change much what we're saying if we just looked at it, you know, for the states.
Yeah, so I think, yeah, is kind of that way because of how politically sensitive it is. You know, but the thing is that most times we conduct some of these studies, you know, for them to be used, for the data to be used, you know, for, you know, program planning and policies and all that. So, I mean, if we keep probably holding back very relevant information because it's politically sensitive. So the issue is, when are we going to talk about these things? And then how do we even start solving the problem if we don't have the right granular, level of evidence that backs up whatever we're trying to correct? So that's why I was a little bit worried. Somehow I had an idea that it's actually kind of worse in some parts of the country, and I wanted to kind of hear that, because that's where most of the focus, needs to be in terms of solutions.
All right. Thanks to both Femi and Chibo for that interaction. Okay, so in the few minutes that we have left, oh, Vimbai, I see your hand up. Okay, please go ahead. Unmute.
Just a quick question for Lucy. Lucy, did you do any quality assessment of the papers that you looked at?
Yes, but not using a sort of specific checklist, because I had so many papers. Doing sort of the whole cheers checklist or whatever would have been too much. So I sort of selected, what I mostly looked at was the reporting standards within the outcomes that I was looking at. So that's kind of my sort of more of my quality analysis, but I haven't done a full checklist assessment.
Thanks.
Okay. Oh, sorry. Go ahead, Vimbai.
Thanks. I was just asking because I'm struggling to I'm just struggling to pull out useful information from the checklist. So I was just wondering if you've done that. Thanks.
Okay, so that kind of gets to what I'm going to ask each of you to do next. So let's go. So starting from the first presentation and working our way through to the last presentation, I want you to, in 2 sentences, if you will, tell the group what your main finding is and what one policy implication is, so that we all have something that we can, take away from this session. So, Rolando, is he here? Rolando, yes. So let's just go in the same order in which we went. So this is really short and sharp. So tell the group, here is the key finding, and here is one policy implication from the work that I've done.
My main finding is that child poverty affects differently boys and girls. Girls have a higher prevalence of time poverty, and this has a long-term effect on their cognitive development. The policy implication would be first to implement policies to close these gaps in the time use of the family, because I think that the reason why women or girls have more temporary prevalence is because their time use is linked to their mothers. So we need to close these gender gaps on time use since the early childhood.
Okay, who's next? Is Mario still here?
Yes, Mario is there.
Okay, Mario, can you, so you guys, you don't need to wait for me, just go one after the other, just quick takeaway, quick policy implication.
Well, my policy implication of my study, like welfare institutions have to check more about the help that they provide to the family that their parents are unemployment, because this is going to have an impact on the long-term health of the children, and that will be that.
Okay, so in my case, we use over 40 years of historical data to show that an intervention to reduce malnutrition can have medium-term educational impact, a positive income in educational outcomes. And as the pandemic has deepened the problem of malnutrition in many countries, especially in wasting and undernutrition, this could be useful evidence for providing nutritional interventions in other settings.
And I think in my case, I've discussed it, the findings is that, getting pregnant early does affect how many years of education girls attain and whether or not they complete secondary school. And the policy implication is that, just to encourage, especially we know that this is concentrated in some states in Nigeria, encourage not getting these girls married that early, like 10 to 14 is kind of ridiculous. And even if they do get married, this is Sharia law. It has a religious background in it. Maybe delaying childbearing till at least age 9, an adult.
All right, thanks a lot. Lucy, quick.
So the finding is that there are inconsistencies in how cost utility analysis is being conducted in pregnancy. The policy implication of that is that if we're inconsistent in how we're conducting economic evaluations, we are probably being inconsistent in how we're investing in those health interventions, which could lead to decision making that is not in keeping with our sort of societal preferences.
Thank you. Jessica?
So the main conclusion is that up to 2 years after the end of the Ebola epidemic, maternal healthcare access was still reduced compared to what we might expect in communities that had big epidemics. And the big policy implication is that post-COVID-19, we need to do more to address access that's depressed by epidemics.
Excellent. Timo?
Right, thank you. So our major finding here would be that the cost of strengthening the quality and standards of delivery of maternal health, of integrated maternal health and NCD care are quite tenable. So it is not really as cost or resource intensive as you would imagine it to be. And the policy implication here is that there needs to be some kind of shift from programming to reduce maternal mortality and morbidity from direct causes, to these indirect causes from, conditions like some of the non-communicable diseases that were covered in our conference study.
All right, thank you. Vimbai?
I think the main finding is that most of the studies use task shifting models using non-specialist healthcare workers, but more work needs to be done on the costing of including the scope of work and time use, so that the models include excess capacity and how that affects cost effectiveness, so that human resourcing can be costed properly.
All right. Okay, thank you. So with that, we come to the end of the session. I would like to thank all of you, for the short but informative presentations. So I'll encourage each of you to, if you can, evaluate the session afterwards. So there is, I think, a button on the page where you can click, and I think it's just one question that you have to answer. My understanding is that the recording of the session will be available, I think, about a week or so after the conference. So you will, I think, have a chance to access it then. All right, so I think that's it. Again, thank you very much, and I've enjoyed listening to each of you. Thank you. All right, bye.
Thank you
Thank you very much. Thank you very much.
Bye, thank you.